Can you see my presentation, New Therapies for SLE?
Sí, sin problema.
Okay. Actually, I did not include my disclosures on the previous presentation, but they are the same. These are my disclosures. In this case, it's also relevant that I added a journal called Lupus Science and Medicine, which is an open access journal for papers that deal with lupus. Now, I told you I came from Amsterdam, and I told you that Amsterdam is in the Netherlands, but I wasn't quite sure that all of you know where the Netherlands is. So I wanted to show it to you on a map. And this is a map of the world. And I'm sure you can find your own country there easily. And Holland is not so easy to find, but it is in Europe. And I don't know if I can point. I can see the pointer on my own screen, but maybe you cannot see the pointer. Can you see the pointer? Maybe not. Holland is the very little country in Europe. It's so small that you can almost not see it. And this map of the world may look a little bit different to you from what you're used to, because it was made by the World Mapper homepage, where the country size is exactly right. You know, many world maps are distorted, and the more northerly countries are made bigger. For example, Canada is made very big on maps, but it is big, but it's not really as big as it looks on some of the maps. And especially Greenland is, you know, it's not so big, but on the maps, it often looks like a very, very big island. And this is a known distortion because the Earth, of course, is a globe and the map is flat. But this map was made to give the exact right size to the different countries. And unfortunately, but Holland is a very small country. That's what I'm trying to say. Holland is a very little country in Europe. But you could actually also adjust the map. So on this map, you can see that, like I said, Canada is a big country. Russia is a big country. In South America, of course, Brazil is the biggest country. And you could look at the countries by size, but you could actually change the size so the size looks like the population of the country. That is a trick, and a computer can do it. So on the next map, every country is still going to be there, but the size of the country will now be how many people actually live there. So if you do it, the map starts looking a little bit different. This is what the map looks suddenly like. So in South America, Brazil is still the biggest country, and perhaps it didn't change the proportions so much. In North America, though, it's very strange because suddenly Canada has almost disappeared. See, Canada is a very big country, but there's not so many people living there. On the other hand, Mexico seems to have gotten a little bit bigger. In Europe, the countries that you probably can recognize, like England or Italy, they're still there. But Holland, which was so little, is actually bigger now. It's not so little anymore. It's easier to see it. And that's because Holland, even though it's a very small country, has a big population. Also, you can see that China is a big country, and India, which was not such a big area, is now a very, very big country. And Australia on the far right, which was actually a big country in terms of surface, has almost disappeared because not so many people live there either. So the population gives you a different picture of the world. And now the third picture I want to show you is again the map of the world, where each country has the size of its scientific output. So this is a very different map. If you do it that way, you get a very different map of the world. The United States is very big. Much of the scientific output from the United States. On the right side of the map, Japan is also actually a very big country. Japan produces a lot of science. China is not so big, but this map is a few years ago. I think China is growing in science output. And the European countries, France, Germany, they have a lot of science output. But here also, you see the one in the middle, that's the Netherlands. So in science output, we are actually doing quite well. And I'm a little bit proud of that our very, very small country with a bigger population actually has a very good science output. And one of the reasons is, of course, that our forefathers in the Netherlands always thought that it was important to support universities. So we have many universities, and the public is still very supportive of that. So we try to deliver on the mission that our science should also benefit society. If you visit Holland, this is a good time of the year to visit it. I know that with COVID, it's not possible to travel, but maybe in some time in the future you can visit. And this is the time of year when you can see this. Flower fields, tulips and other flowers in large, large fields. that give beautiful colors. But I'm not here to talk much about tourism in our country. I am here to talk about systemic lupus erythematosus. And of course, you all know systemic lupus erythematosus as a disease that is very heterogeneous with many different manifestations: skin, the joints, the pleural surface, the kidneys, gastrointestinal, hematological, and so on. And these are all present to varying degrees in different patients. And two patients with lupus may have completely different clinical manifestations, and we still say that they have the same disease, SLE. Now, some of the manifestations of lupus are clearly the autoimmune disease itself, but what is making it difficult for clinicians is that many symptoms and signs could be related not so much to the disease, but to the treatment. And that's illustrated on the right lower picture, where somebody's having terrible joint and bone pains, but it's not because of the lupus, it's because of the corticosteroids. So this is a problem that is very notable with lupus, that the patients may have symptoms due to the treatment and long-term damage due to the treatment. And one of the goals of therapy is, of course, to try to prevent it. So one of the questions is, how good are we at treating lupus? And my answer is that we are not so good. And I will show you two studies that illustrate this. So the first study is on the left, and this study was done by Christine Bexelius, who worked with me in Stockholm in Sweden at the Karolinska Institute. And she looked at the cross-sectional patients with SLE. So we took all the patients that had SLE at that time that we knew, and we contacted them and we asked them to fill out a questionnaire. And the questionnaire had many elements, including the quality of life. And the quality of life can be measured by something called EQ5D. It's 5 dimensions. And it showed that the average quality of life was 0.64. And that is on a scale of 0 to 1. On this scale, if you have a perfect quality of life, it is 1.0. If you are dead, it's 0. It is possible for the quality of life to be negative, because there are some health states that are so bad that people will say it's worse than being dead. But most people, fortunately, have a health quality of life value that is between 0 and 1, and the higher it is, the better. Now, for lupus, the average is 0.64, which means that for some people it is good, they're close to 1, others it's bad, 0, but this is the average. And to give you an idea what that means, that is similar to patients with advanced COPD, lung disease, patients with treated HIV disease or Hodgkin's lymphoma, and patients with type 2 diabetes. So lupus gives a decrease in the average quality of life that is quite substantial. The morbidity of lupus is still substantial. The study on the right side was done more recently by Dr. Irene Bultink in Amsterdam, and she looked at the mortality of patients with lupus in a large population-based data set. And we found, a little bit to our disappointment, that there was still quite considerably increased mortality, death rate, for patients with lupus compared to healthy controls. And the increase was most clearly visible in the younger patients, those between 18 and 39 years of age. Now, for these patients, of course, the absolute mortality was the lowest. So it was still a very low number, but the relative increase was quite big for lupus. And that is disconcerting. We saw that there was also an increase in mortality in the higher age groups, and the average increase in mortality was about twofold, a doubling of mortality in relationship to lupus. And here too, we can say that it's not always clear if the mortality is because of the disease itself or because of consequences of its treatment. So that was not analyzed here, but we know that probably both do play a role. Now, to get better treatments for lupus, we need to understand more about the immunopathophysiciology, the mechanisms behind the disease, what is really happening in the immune system in these patients with SLE. And we know that it is very complicated. We know there are some triggers, genetic factors, environmental triggers, ultraviolet light. Things are wrong in the patient with lupus when it comes to apoptosis. The breaking down of cells does not work well. We do know that this leads to the spreading in the body of nucleosomal materials. And then we also know that there are many different immune responses that take place in terms of T cells and B cells, and also pathways that involve cytokines. And each of these different components of the pathophysiology of lupus allows us to also try to think of treatments that are specific for that component. And I'll start by talking about the component on the right lower part, which is the B cell component. B cells differentiate into plasma cells, and plasma cells produce antibodies, including autoantibodies. So it is very clear that B cells are in fact involved in lupus. This has been known for a long time. And it turns out that yes, we can actually do something to deal with B cell hyperactivity or B cell dysfunction in lupus. These are the results from the Bliss trials, where belimumab was tested in patients with lupus, and it was compared to placebo. And it was already shown that this was an effective treatment from the trials in general, but in this analysis, the data from the trials were combined, and then they were analyzed by patient subsets. And the graph on the right side showed general pool data. So this is for all the patients. And you can see that the white is higher than the gray. So with belimumab, more patients responded than with placebo. And the difference is statistically significant. But if you now look on the left side of the graph, you see the same analysis, but here it is for patients who have anti-DNA and low complement. And for those patients, the difference is much bigger. It's also, of course, statistically significant, but it's certainly much more clinically convincing and clinically important. So it was decided based on these results that belimumab could be considered a very suitable and appropriate treatment for patients with this particular phenotype, anti-DNA and low complement, as well as, of course, having active systemic lupus erythematosus and having failed other treatments. And that's how belimumab was approved as the only biologic so far to be approved for systemic lupus, and how it is being used since then. And of course, the trial was in part intended to get the approval, so it was good that it met its endpoint. And later, a study was also done with subcutaneous belimumab with the same results. And these are the same results in a different graph. And I do want to add that we were always curious to find out if belimumab could also be a steroid-sparing agent. I mentioned that it's so important to prevent damage. And so you can ask the question, if you treat patients with this drug, with belimumab, do they need less prednisone? And the answer is yes. And that was shown in this analysis that was published a few years ago. And the main answer is on the right side. And you can see that the difference between the groups is statistically significant, but you can also say that the difference is not very big. So there is a steroid sparing effect, but it's a modest effect. It's not a very strong effect. Part of that may be also because of the way the trial was organized. So we need to be careful, and we are still looking at other data sets for the true steroid sparing effect for belimumab. It is there. How big it is could also maybe be different from patient to patient. Now, the real new thing about belimumab is that this year it was published that it was effective in lupus nephritis. Remember, the data I showed you so far about belimumab were done in general lupus, patients with mostly the skin, the musculoskeletal manifestations, the general manifestations, but not in the patients with lupus nephritis, because the severe lupus nephritis was excluded from those trials. This trial, which is on the screen now, was done in patients with severe lupus nephritis, class 3 or 4 WHO lupus nephritis. It was a phase 3 trial in almost 450 patients, and they were randomized to receive belimumab or standard therapy added to belimumab or placebo added to the standard therapy. So they all received standard therapy, which of course we know is mostly mycophenolate, but it could also be urolupus, and then corticosteroids. And to that was added belimumab or placebo. So you can see that with the standard therapy, 32% of patients achieved the primary efficacy renal response, which was defined prospectively, and which was like a renal remission. And that percentage was 43 for the patients where belimumab had been added. So it was more than 10 percentage points more, and that was also highly statistically significant. And you can say that it would be clinically relevant, a difference of more than 10 percentage points. So it seems that the addition of belimumab was beneficial at a level that you would say could change the way we manage lupus nephritis. The question, of course, is, well, then should we give it to all patients with lupus nephritis or to a subset? And there's a debate about that. And I was at the Lupus Academy a few weeks ago, and two very experienced colleagues, very wise colleagues, Professors Boompas and Professor Tang, they debated on this, and they took the opposite position. And Professor Tang said that you would have to treat all patients with conventional therapy plus belimumab. And Professor Boompas said that that would not be necessary. You would only have to do that in some patients. So we'll see, and this is also a question for more study and also a little bit about practice. But belimumab has been shown to be effective, and it has been approved in the United States by the FDA and by the EMA in Europe. I don't know about Chile, but I would say if it has not yet been approved, it would be expected that soon it will be approved elsewhere, because the trial is very clear. And then it's a new treatment for lupus nephritis, which is the first time in a long time, except that there is another treatment that was also approved this year. And I don't have a slide, so I'll just mention it in words. Voclosporin has now also been approved. Voclosporin is a calcineurin blocker, which is similar to cyclosporin, similar to tacrolimus. And voclosporin was tested in phase 3 trials and was successful. So it has now also been approved for the treatment of lupus nephritis. And again, it is as an addition to standard therapy. And with voclosporin added, there was clearly a better result than without it. And this is an oral agent. So that's, like I said, it's similar to cyclosporin, similar to tacrolimus. And of course, cyclosporin is known to people who treat lupus, but it has the nephrotoxicity, which is a clear disadvantage when you treat lupus nephritis. And with voclosporin, that does not seem to be the case. So that's an advantage. And generally, it was also better tolerated. So we are now in the unusual position that suddenly there are 2 new approved treatments for lupus nephritis. And we are still going to have to find out a little bit more about which one we're going to use in which situation. For which patient do we choose one? For which patients do we choose another? Are there patients where we don't choose between this? So this is very interesting, and we are going to find out more about these options for lupus nephritis. And then I was going to say there is a third option, but that's more in the future, because this is not for now. And this is actually a story. And this story has 3 chapters. From left to right. The first chapter was about 15 or 20 years ago, when several groups, including our own at Karolinska, showed that a patient who had been very seriously affected by lupus nephritis was doing very, very well after she was treated with rituximab, the B-cell depleting agent. And rituximab was shown in several large case series to be apparently a very effective treatment for lupus nephritis, even in patients who were refractory to conventional treatment with, for example, cyclophosphamide. That was the first chapter. Everybody got very excited. Everybody got very happy and said, we have a new treatment. And then it was tested in a randomized trial. And that's the second chapter in the middle. And you can see that the results in the trial were not convincing at all. In fact, the trial was negative. There were no significant differences between rituximab and placebo. This came as a major disappointment to many of us. And of course, that also was quite a disappointment to the company, and it was not developed any further as a treatment for lupus or lupus nephritis. And since then, rituximab has had a strange position because, of course, it is available. It's used for other indications. And lupus experts still feel that it can be used sometimes in patients with very severe disease, including lupus nephritis, but it's never been approved. and it probably will never be approved because it's not being tested in large trials. And there was the one negative trial. So that's unusual. And now there's a third chapter. And this chapter has to do with Obi-Datuzumab. And Obi-Datuzumab is also a B-cell depleting agent. It is also anti-CD20. That's the same as rituximab, but it's a little bit different. And the difference may be that it penetrates the tissues better. And in a press release, it was announced that Obi-Datuzumab was very effective in lupus nephritis. And the results of the press release are shown on the right side. It has not yet been published. And also note, this is a phase 2 trial. So to get this drug to be approved would actually mean that would have to go to a phase 3 trial, and that will take several years. So this is not available, but it's very interesting. I did want to show it to you because B-cell depletion is still there. And after all, we were talking about how to tackle lupus by tackling the B cells. And that's what we're doing with this approach as well as with belimumab. So we talked about approaching lupus by targeting the B cells, but as I already mentioned, there are many other pathways involved in the lupus mechanism, and we can try to control lupus by addressing a different part of this. And the part I want to talk about now are the cytokines, because of course in rheumatoid arthritis, as we discussed an hour ago, the cytokine approach has been very successful. Why shouldn't we do the same thing in lupus? And there are some attempts. Now, you can block cytokines with a monoclonal, like an anti-TNF, but you can also use the JAK inhibitors, and that is actually a way of downregulating cytokines indirectly. So it all fits into the same pattern. And this was done with baricitinib. Baricitinib was tested in a lupus trial where patients were given the 4 milligram dose or the 2 milligram dose or placebo. And as you can see, there was a response, there was dose response. And on the right side, you can see that the difference was actually quite substantial for the primary outcome after 24 weeks, the SRI-4. And that was, of course, also statistically significant. So now a phase 3 trial is underway with baricitinib. I believe it has enrolled fully. So now we're just going to wait for the results. And it might be that JAK inhibitors are going to turn out to be effective for lupus as well as they are for rheumatoid arthritis and other diseases. And then there is the central mechanism of type 1 interferon. And I think that most lupus experts will agree with me that this is right now the hottest topic, that it's very exciting because there are things happening that could pave the way for completely new treatments, but we'll have to see. Type 1 interferons clearly play a very important role in the mechanisms of lupus. This has been shown by the work by many investigators, including Lars Rönnblom in Uppsala in Sweden, who showed that individuals with lupus have high levels of interferon in their serum, in their plasma. They have the interferon signature, which is that the cells, the white blood cells, are also responding to the interferon. It is also clear that interferon polymorphisms are linked to lupus. And there is also a feedback loop where the interferon production actually also triggers more immune activation. So we can clearly see how interferon could be a very central cytokine in lupus. But the proof, of course, will be if you then try to block it. And this was done with a monoclonal called anifrolumab. These are results from a phase 2 trial. The overall results are shown on the bottom. And you can see that the two different dosages of anifrolumab were much better than placebo and quite similar to each other. And the illustration is, of course, a patient with very severe cutaneous lupus who responded very nicely after 40 weeks of treatment. Now, this is an intravenous treatment given every 4 weeks. And this went to a phase 3 trial program. And the phase 3 trials, there were 2 of them, and they have both been published. One of the trials was nominally a failure because it asked the question if anifrolumab can give a better SRI response. SRI is the SLE responder index. And there was a difference in the SRI response, but it was not statistically significant. Now, in that trial, which was the TULIP-1 trial, in that trial, there were other things that did look good, but the trial has to be called formally a failed trial. This is the TULIP-2 trial, which was successful. This trial had the BICLA as the primary outcome, and you can see in the left upper panel that the patients who were given anifrolumab, 300 milligram every 4 weeks, had a better BICLA response at almost every time point compared to placebo, and at many time points this was also statistically significant. So for the primary endpoint, this trial was clearly successful. Another endpoint was on the left lower panel, which is to ask the question if patients who were treated with anifrolumab will have fewer flares compared to those patients who are treated with placebo. And indeed, you can see that the hazard plot is lowered by anifrolumab, so fewer patients get flares, or they get the flares later in time. And that was also statistically significant. Now, with those two very good results and many other secondary outcomes, you can start asking the question, oh, if anifrolumab is a good treatment, is there a subset of patients who are particularly likely to respond? And that was analyzed with the forest plot on the right upper side. And what you would like to see is that the pairs are different. But in fact, if you look, for example, at the patients with the interferon signature, or the patients who do not have the interferon signature, and you look at the two black dots, those two black dots are actually pretty close to each other. It would have been nice if they would have been very separate, but they are not. And so a little bit to our surprise, the interferon signature does not predict for which patient this is a good treatment. And this is also a practical point, because we were thinking for a long time that if this drug would get approved, it's not approved yet, but if it would get approved, maybe it would have to be that you first test the patient with the interferon signature, and then you can treat them if they're positive. But these analyses do not support that. They say that it doesn't make so much difference. So this is a little bit, it's good because it means that patients with or without the interferon signature could benefit from the treatment, but it would be nice to have a biomarker, and we don't have it yet. You can also ask the question, if the same phenotype that was so successful for belimumab, which is anti-DNA and low complement, that it would make a difference for anifrolumab as well. But that turns out not to be the case either. Again, the two black dots are pretty close to each other, obviously not exactly, but they're pretty close. So you can say that with this, it seems that whether the patient has anti-DNA or low complement doesn't make so much difference. You can try anifrolumab if it becomes an available treatment in both cases. The final point about the anifrolumab story is that there's something that didn't make so much difference, and that was the anti-DNA. These are the anti-DNA levels in patients who were treated with placebo in the blue line, or with anifrolumab in the purple line. And you can see that there's a little difference, but it's a very small difference, and the confidence intervals are very wide. So in fact, you would have to conclude that this treatment does not seem to have much impact on anti-DNA. In contrast to the B-cell therapies, belimumab and also anti-CD20, they do lower anti-DNA. So this does suggest that it's a very different mechanism, which is, I guess, a good thing, because it means that different patients may benefit from the different treatments, and more patients in total will end up doing better. There's a final way that I want to introduce to you for targeting interferon. See, the interferon is not coming out of nowhere. It is made by certain cells. And which are the cells that produce the interferon? It's the plasma cytodendritic cells. Now, some of you may not even have heard about plasma cytodendritic cells. These are a very rare kind of white blood cells. Of all the leukocytes in the circulation, they make up at most 1%. But they're very important because they produce almost all the interferon type 1 that's there. So they're very important for fighting of viruses, perhaps for cancer surveillance, but they also play a bad role in lupus. And these cells can be targeted by a monoclonal antibody called anti-BDCA2. And this was done now in 2 small trials, one in cutaneous lupus and one in systemic lupus. And the results here are for the cutaneous lupus trial. And you can see that all 3 dosages of this antibody, that's also called BIB059, that all 3 dosages were were much better than placebo. So this first trial of the antibody BIB059 was successful for the skin. And there was a second trial that was presented at the ACR Congress last year. And it showed that patients with lupus in general also did better with this treatment compared to placebo. But very early trials, very small trials. So we're still going to have to wait for confirmation in much bigger studies. So I'm reaching the conclusions already, a bit early for this talk, but maybe we're also ready for taking some questions soon. If you want to talk about new treatments for lupus, I think the first part is that there is a very significant increase in our understanding of the immunology of lupus, and that leads to better therapies. And then if you say, well, what has emerged from these pathways? Well, certainly the B cells have been targeted. Belimumab is an approved biologic, and now it has even been approved for lupus nephritis. It was successful in the largest clinical trial program that led to approval. So it was in the Bliss Trials, it was shown that it was effective for general lupus. Now in Bliss LN, it was effective for lupus nephritis. It's effective as a subcutaneous form. And of course, it was particularly effective for patients with anti-DNA and low complement. So there are many interesting aspects of belimumab, and it is being used. And it will have more use now that it's approved for lupus nephritis. We also target B cells with anti-CD20, but that's not approved, so that remains off-label. And there may be some future developments when it comes to that. Then there's JAK inhibition. Baricitinib is in phase 3 trial. There may be other JAK inhibitors or other tyrosine kinase inhibitors that are also going to be effective. And then there's the interferon story. And as I just mentioned, we think that's a very exciting story because the phase 2 trial and one of the phase 3 trials with anifrolumab was very successful. The other phase 3 trial did not achieve its endpoint, but the totality of this still looks pretty good, and the regulators will have the final word. They will be able to say that they can approve it or not based on these data. And then I showed you just a very early stage result with anti-BDCA2 antibody that also in fact targets interferon. But I think that the overall message, the final conclusion, is that all these efforts taken together in combination will result in a situation a few years from now where the treatment for systemic lupus erythematosus will be radically different from what it is today. And I believe it will be to the benefit of many of our patients with lupus. Thank you very much.